So we are live.
Okay.
So, Dr. Sandeep sir, have you joined? Dr. Sandeep Grover sir? Hello.
Dr. Sandeep, you are mute. I think you need to unmute yourself.
Yeah,
Yes.
I've joined.
Yes.
Good afternoon, sir.
Yeah, good afternoon. I have a problem in
It
from
is
my
2 now. So it is 2 now. So should we start now? I think we should start.
we can start.
Yes, yes. Okay.
Yeah. Good afternoon,
So,
Suresh. Yeah, please go ahead.
yes.
Sorry.
Good afternoon, everyone. I welcome all of you for this very interesting webinar today. This is about a very happening theme about of gut-brain axis, or sometime now we call a gut-brain microbiota axis. As we all know that dysfunctions in stress response mechanism plays an important role in gut-brain axis. And a lot of times similar genetic, molecular and biochemical mechanisms are partly responsible for etiological and clinical manifestations in some of the functional gastrointestinal disorders and some of the disorders related to psychiatry. Symptoms in psychiatric disorders, several of them, and a group of medical disorders, which now we are calling functional gastrointestinal disorders, are also very closely related at times, and in clinical practice, we commonly see such kind of patients. Enteric nervous system, as we know that we call it second brain, because it has a large neural network and it can sometimes independently work from nervous system. In addition, the microbiome is being considered an independent human organ with its great impact on development, maintenance, and functioning of human brain. Thinking, emotion, and behavior in both health and disease are seen to be influenced by the microbiome of an individual. So I hope that this cross-talk between the specialties of psychiatry and gastroenterology is likely to help about the improving opportunities for research, better clinical consultation, and better patient care for the patients who often seek consultation from both gastroenterologists and psychiatrists for improving their clinical conditions. I will now introduce our very renowned chairpersons. Our chairpersons, although do not need any introduction for psychiatric fraternity, but there are a lot of persons from other disciplines also in this webinar. So I'll introduce Professor Suresh Badamat. Professor Suresh Badamat is MD and DNB from NIMHANS, Bangalore. He is also holds several degrees in relation to law, which is his very important area of interest, that he is very interested in forensic psychiatry. He is currently professor and head of telemedicine center, head of forensic psychiatry services and consultant in community psychiatry. He is visiting faculty of National Law School, Bangalore, State Human Rights Commissions, Karnataka, and Judicial Academy, Bangalore. He has 282 publications to his credit, and he has received several awards of within psychiatry and outside psychiatry. Our other chairperson, Professor Sandeep Grover, is a very well-renowned researcher of India. He is a well-known academician and has more than 300 publications to his credit. I just saw his Google Scholar profile, and he has more than 9,000 citations to his credit, and he's very well-known researcher in consultation license psychiatry. With this, I hand over the proceedings to our chairpersons.
Very good afternoon to all the participants and also to the presenters. First, I would like to introduce the first person, Vikas Menon, sir. I think he has been a very wonderful person who has accepted our request to come here. Okay, he's additional, Dr. Vikas Menon has finished his MD and DNB. He's additional professor of psychiatry from JIPMER, Pondicherry. Completed his MD in 2008 and DNB in 2009. His area of interest is consultation license psychiatry, digital psychiatry, suicidology, and mood disorder. And he has 180 publications from the Index Journal. He has won 3 Indian Psychiatric Society Research Awards, and he's a chief associate editor of Indian Journal of Psychological Medicine, deputy editor of Indian Journal of Psychiatry. With this, I now call Dr. Grover sir to mention few things introducing the topic.
Uh, 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 I think Dr. Adarsh has already talked about what we are going to discuss in the today's webinar about the gut-brain axis. And we all know that it's a common saying in India when we talk about the gut and the mind of the brain, that whenever somebody has to understand somebody, the best pathway is to go through his food habits and try to understand what he likes and what he does not like. So that is the basic thing which we need to understand, from where the gut brain axis starts. And many times we talk about gut feeling. See, this is something that whenever we talk about any kind of feeling, what do you feel, how do you feel about it, it's called as gut feeling. That again indicates that what you perceive in your brain is somewhere related to your gut. So we need to understand that there's a very strong relationship between the gut and the brain. Till now, we did not had much understanding about this association, although we knew, if we talk about the earliest description of the Holy Seven, as described earlier, that uh, in that list, again, we had the disorders from the gut-brain axis, but nothing was understood much at that time. In last 2 decades, a lot of things have emerged, and we have started understanding the neurobiological underpinning, and we also have developed a better understanding about the gut microbiota. How does that influence brain, and how there is a close relationship between various neurocognitive functions and the gut microbacteria. Keeping this in mind, we thought of starting this whole webinar series by first focusing on the gut feeling. How do we feel about this whole thing? So that's where we are starting. And I'll first now request Dr. Vikas Menon, my dear friend, to introduce the topic, how we are going to go about that. Yeah, Vikas, please.
Thank you, sir. Thank you, Sandeep sir. Thank you, Suresh sir, for the kind introduction. Already, some thoughts have been proposed on the gut-brain webinars. I will just try to take it a little further. I'm very happy to introduce this topic, which is very interesting as well as very fascinating. So
इसके बाद आप इंट्रोड्यूस कर दीजिएगा डॉक्टर घोषाल को, मैं ये कह रहा था, ठीक है?
So the gut-brain axis, in recent years, a lot of new insights have emerged into the complex communications between the central nervous system, the autonomic nervous system, enteric nervous system, and the hypothalamo-pituitary-adrenal axis. Perhaps it is the complexity of this interaction and this interplay that denotes the term the gut-brain axis. Now we know that there is a bidirectional relationship between the brain and the gut, in the sense that changes in the brain that are produced by various kinds of emotional and physiological stresses can produce changes in the gut microbiome composition, alter intestinal permeability, while at the same time, changes in the gut microbiome can also signal the brain through immune regulation, modulation of afferent nerve fibers, production of various microbial metabolites like short chain fatty acids and microbial neural substrates. There is also now a proposed etiological role for the gut-brain axis for several diverse neuropsychiatric conditions like stress, anxiety, depression, schizophrenia, bipolar disorder, autism spectrum disorder, a whole range of neuropsychiatric conditions. And what is most heartening to note is, while our knowledge and understanding about the gut-brain axis is still evolving, we have already been able to leverage the knowledge that we have in developing new treatment targets for neuropsychiatric illness. I think the evidence for this is in the, though limited, there are positive trials of agents such as prebiotics and probiotics. So that is one way how we have been able to develop new treatment targets for a range of neuropsychiatric conditions. Coming to the condition proper that we're going to discuss for the day, that's irritable bowel syndrome. It's probably one of the most common presentations under the rubric of functional GI disorders. It's quite prevalent in Asia. Estimates range from 5 to 10% depending on the definitions used. marginally more prevalent in evidence from the Western literature. And various famous personalities have been documented to be suffering from irritable bowel syndrome, like President John F. Kennedy and Marilyn Monroe. But this may not provide any vicarious relief to sufferers of this enigmatic illness, because, make no mistake, the disorder substantially impairs the quality of life and contributes to high healthcare utilization costs, often with less than satisfactory benefits. A lot of studies have tried to compare physiological functioning between patients with and without IBS, but till date, there is no definitive agreement on the underlying physiological mechanisms. There is evidence for bowel dysfunction driving the symptoms of IBS, like altered gut motility, visceral hypersensitivity, while at the same time, evidence for psychological and neural phenomena that may explain IBS, like increased rates of morbidity of depression and anxiety conditions, structural changes in the brain, altered top-down pain modulating mechanisms. So perhaps it's more of a biopsychosocial model into which we can unify all these factors, as shown in this figure: biological factors like genetics, immune inflammation, psychological factors like childhood abuse, social learning patterns, and social factors like family background and beliefs. And you can see the bidirectional communication between all the biopsychosocial factors that results in these disorders. Perhaps this model is not very specific for IBS alone, but also relevant to other conditions where pain symptoms are predominant, like migraine, tension headaches, and also fibromyalgia, to name a few conditions. So while the jury is still out on whether it's primarily a disorder of the bowel or the brain, I think it's very nice that today we are having an interdisciplinary crosstalk, because multidisciplinary and multimodal management of IBS has been linked to better outcomes, clinical and functional outcomes. And with this brief introduction and without much ado, I'm very happy now to hand over the platform to our renowned speaker, Professor Uday, for his expert deliberations on this topic. Over to you, sir.
Before we start the presentation, I would like to introduce our speaker now. The speaker is Dr. Uday C. Ghoshal. He passed his MBBS from Burdwan Medical College. And let me tell you, he has 8 gold medal and university first position in all the 3 professional examination. That is basically MD, DNB, DM in Gastroenterology from SGPGI, Lucknow in 1995. He is also American College of Gastroenterology, FACG, Fellow, Roman Foundation, Fellow of National Academy of Medical Science. Currently, he is holding the professor in the Department of Gastroenterology in the Sanjay Gandhi Postgraduate Institute of Medical Science, Lucknow in India. And also, because his CV is so big, I'll be mentioning only the highlights. And he has more than 300 publications. And also, very important thing is he's a visiting clinician, basically for Mayo Clinic in US, and also fellow of World Health Organization at Prince of Soklo University. And with this, I think we could have not got a better resource person than this. I think we should not waste our time. Uday sir, please go ahead, sir. Sir, you are mute. Please unmute, sir.
Yes.
Thank
you
let
for
us
the
please
kind
see
introduction.
that somebody is saying that audio is not proper. Is it proper? Everybody is able to listen audio properly?
Yeah, Adarsh, it is fine. It's fine.
Okay, so that may be a local issue then. Okay, yes, Ghoshal sir, please.
It is very good to share with you the gastroenterologist perspective. So basically, until unless the gastroenterologist and psychologist or psychiatrist work together, probably will not do great to our patient suffering from this group of disorders. Now, a lot has been said about irritable bowel syndrome, and we are going to talk about where we too, the psychiatrist and gastroenterologist, can come together. But before going to that, let me tell you, anybody can would ask someone is disorder in general, study on gastroenterology till date. What we did is we studied 33 countries, 6 continents, more than 73,000 adult people. And we found functional gastrointestinal disorder are not uncommon, quite common. In fact, if you look at IBS in general, people who did not consult a doctor. So this is a common disorder. And where we can stand together is how do you diagnose this condition? I know in psychiatry, you diagnose by DSM criteria. Now in gastroenterology, let me tell you, if you ask anybody or everybody in the world, how commonly do you have GI symptom? Almost half or maybe more than that number of people would say, sometime I had heartburn, sometime I had early satiety or nausea, sometime I had abdominal pain, diarrhea or constipation. But they are not suffering from any disorder or disease. The reason is that if GI tract has to digest 350 kilogram food 350 kilogram food every year, it is going to have some disturbance, sometime or the other. Like in psychology, we are all different as far as our psychic makeup is concerned. Still, you don't call everybody is mad. Similarly, or suffering from a disorder. Similarly, we, the gastroenterologists, do not label everybody as having functional gastrointestinal disorder. What we do is that we go by a threshold, a cutoff value, above which, if symptoms are there, then we call them having functional gastrointestinal disorder, one of which is IBS. Why do we do so? Because we found that if people crosses that threshold of symptom as far as their GI condition is concerned, then they are little abnormal because they have impaired quality of life. They are the one who consult doctor. They are the one who have work absenteeism. And that is the reason above this cutoff level of symptom, we consider them as having a disorder. Now, what is that cutoff level? In IBS, we just released Rome criteria in the beginning of 2016. And we found that if somebody is having a recurrent abdominal pain, at least 1 day per week, in last 3 months, associated with 2 or more of the following, the pain is related to defecation, pain is associated with change in the frequency of the stool, pain is associated with a change in the form of the stool, which we depict by Bristol stool form scale, which I'm going to show you to now. Now, the symptoms should be present during last 3 months, meaning thereby the fellow is symptomatic. The fellow has active problem now. And the symptom must have started 6 months ago, meaning thereby the symptom is sufficiently chronic to give him this level of IBS. The patient should not have alarm feature. The alarm feature is onset of symptom after the age of 45 years, presence of anemia, blood in the stool, unintended weight loss, nocturnal symptom, fever, abdominal mass, and family history of colorectal cancer. Why are these alarm symptoms important? They are important because if these are present, that basically means we have to investigate more. Maybe the fellow has come to you with symptoms suggestive of IBS, but the fellow have a colon cancer inside. So that is the reason we bother about this alarm symptom. If the alarm symptoms are absent, you are reasonably correct to say he may be having functional gastrointestinal disorder such as IBS. Once we diagnose them as IBS, we subtype because IBS is not a disease, it is a syndrome. And this syndrome means it is a constellation or a combination of the symptom from which patient is suffering. So until unless we subtype them, we cannot treat them. And when we subtype, predominantly we look at whether he has constipation predominant disease or he has diarrhea predominant disease. If constipation is the predominant symptom, if abdominal pain is present, this is IBS constipation. If pain is absent, this is functional constipation. If diarrhea is the predominant symptom, if pain is present, this is diarrhea, predominant IBS. If pain is absent, this is functional diarrhea. But let me tell you, this does not really translate to much difference in the management. Whether somebody has functional constipation or IBS-C, they are treated quite similarly. Somebody has functional diarrhea or IBS-D, they are treated quite similarly. And what happens is, look at the stool form. This is what is called Bristol stool chart, where the stool is predominantly loose. This is diarrhea. This is very, very important. If you ask a severely constipated fellow that how many times do you visit toilet, he may tell you that I visit 5 times a day. But if you do not ask what is your output, you will consider him having diarrhea. That is the reason stool form is important. Earlier, IBS was thought to be a disorder of a brain-gut interaction. So that means brain was thought to be the primary place for the symptom. The gut was secondary. Now, the IBS was labeled as functional disorder. And unfortunately, what happened is this word functional means abnormality of physiology. But people started interpreting this word functional as idiopathic or cryptogen. And the patients were labeled as neurotic, apprehensive, otherwise healthy individual with an imaginary illness. And it is not uncommon to see that patient visiting a gastroenterologist, but the gastroenterologist is not giving much attention to the patient symptom. And this is because he thought this fellow is apprehensive, he is otherwise healthy. But that is the reason we changed the philosophy of IBS. So what is IBS now? IBS means that what are the GI events that are happening and how the brain is sensing those GI events. For example, let us say microbiota has been said in a great detail. So is it that fellow has an abnormal microbiota, fellow has abnormal muscle contractility in the gut, and this fellow has abnormal immune activation in response to the food antigen or the luminal microbial antigen. And this is inappropriately sensed by the brain because of hypersensitivity at the peripheral level and central level. So because a lot of pathophysiological mechanism in IBS we have realized are in the gut, therefore in the Rome 4, we have changed the terminology. Earlier, all the functional gastrointestinal disorder were called as disorder of brain-gut interaction. Now it is changed to disorder of gut-brain interaction. That means gut is the primary problem, brain may be secondary problem, though there are some data to suggest maybe brain is as important, if not less. Now, the word functional has been removed in Rome 4. So we do not call this patient as functional disorder. We say these are disorder of gut-brain interaction, not functional disorder. Only thing is one particular category of this disorder, we could not find a better name. Therefore, for functional dyspepsia, we retain the word functional. Also in Rome 4, something else we have done. We said you don't just stop by giving the categorical diagnosis to the patient. Like in psychiatry, you just don't stop by saying the fellow is depressed. You talk about whether it is a major depression, you talk about whether the fellow has suicidal ideation. Obviously, you are expert in all these. Now, if the fellow is having suicidal ideation, he is treated differently by you than the fellow who has mild depression symptom. So that's why we said you look at the impact that the IBS is produced in him. Is it a mild disease? Is it a moderate disease? Is it a severe disease? Severe disease needs to be treated differently. Also, many a time earlier gastroenterologists were forgetting to look at the psychological issues in the patient. And if there are unaddressed psychological issues, you may give tons of medicine to target the gut problem, but the fellow doesn't become better. So that's why in Rome 4, we made it necessary that all patients should go through multidimensional clinical profile assessment, which will include psychological modifier, where we going to learn from you. You see, where we need to learn from you, a gastroenterologist who dedicate to this field at least should be learning a lot from psychiatrists and psychologists. And we also want physiological dysfunction. That means, what are the physiological abnormalities? Does the patient have slow intestinal transit? Does the patient have fast intestinal transit? And so on. So look at this. IBS is multifactorial: visceral hypersensitivity, altered motility, inflammation and permeability alteration, dietary issues, pathogenic infection, altered gut microbiota, local neurohormonal dysregulation, genetic factor, psychological factor, and stress factor. Also, microbiota is very, very important. This is one of the meta-analysis that we recently published. Also, this meta-analysis included a lot of our original work. And we found patients with irritable bowel syndrome, particularly those with diarrhea predominant IBS, often have microbiota related issues such as gut microbiota dysbiosis and bacterial overgrowth. How common is anxiety and depression among patients with irritable bowel syndrome? And this is again a meta-analysis which looks at risk of anxiety and depression among IBS patients. And as you can see here, patients with IBS are more often anxious than healthy subject. Also, those, let us say in these studies, it also includes some studies which took patients with post-infection IBS. And they found if somebody develops an acute gastrointestinal infection, acute gastroenteritis, if he has a psychological problem such as anxiety, he is at a more risk of developing IBS in the long run. Similarly, if somebody has depression, he has more risk to develop IBS in the long run. This is a fantastic study. This is a study on bidirectional relationship of FGID and psychological distress. This was from Nick Talley's group, Australia. What they did is they took patients with anxiety and do not have anxiety. Those who had anxiety develop functional gastrointestinal disorder in the long run to the tune of about 3%. Similarly, they took patients with functional gastrointestinal disorder, no anxiety, and they followed them up for 12 years to look for how commonly they develop anxiety, and the figures were quite similar. What does it mean? It is bidirectional. A fellow who has IBS, obviously his quality of life is bad, his work absenteeism is high, his boss will fire him more, he will change the job, his scholastic performance will be poor, he's going to have psychological issue. Similarly, psychological patient may have several issues, including the drugs that we give. It changes gut motility, it changes visceral sensation, and therefore that can lead to psychological problem. Also look at this chart. Psychological issues are known to be associated with visceral hypersensitivity, which I will explain to you later. And it is found that if somebody has visceral hypersensitivity, it determines the functional GI disease phenotype. Like I told you, that if somebody has constipation plus pain, he will be called as IBS-C. Somebody has diarrhea plus pain, he will be called as IBS-D. But if somebody does not have pain, this will be called as functional diarrhea and functional constipation. And several workers found that pain is determined by visceral hypersensitivity. That means those who have hypersensitive viscera, they are the one who are going to report pain more. And what is that hypersensitive viscera? Typically, we inflate a balloon in the rectum. We look at the compliance of the rectum. Often these IBS patients have stiff rectum, and at a lesser balloon volume, they report pain. Also, we found that the proportion of patients with IBS who have severe disease, who have overlapping functional gastrointestinal disorder, those who have psychological issues and other non-GI symptoms, and those who visit to the tertiary care, they are the one who have more psychological issues, more visceral hypersensitivity. So if you are sitting in the ivory tower, the third level center, which is called tertiary center, you will get more patient with IBS and anxiety depression center get it. Now, beautifully, people are depressed mood. And then what they did is they gave visceral stimulation. And after visceral stimulation, they looked at the degree of brain activation and the areas of brain which are activated. And what they found is fellow is having neutral mood, the degree of brain activation is much less, and the brain activation is appropriate. That means it is the somatosensory areas which gets activated more. On the other hand, patients who are depressed, obviously they have activation to a greater degree, and they have emotional arousal system activation, not only the somatosensory cortex. Now, this is important because we all know that if somebody has an injury anywhere, the moment the fellow panic, he creates more manifestation. He creates more manifestation. A panicky fellow with a visceral stimulation will have more manifestation. And this is because of different cognition level. And I'll explain to you, we all know this, that the pain sensation in our body is actually modulated. One area of modulation is the posterior horn of the spinal cord, where we know that naturally occurring opiate-like substances, endorphin and enkephalin, they actually do not allow the pain to be transmitted in excess degree to the brain. Also, you have descending pathways which actually inhibit the pain sensation in a subcortical level. And we also know that if there is a emotional arousal system activation, this leads to panic, and panic determines consultation behavior. Many IBS patient has been there with their symptom for long, but the fellow has one near relative dying of colon cancer, so he becomes panicky and comes to the doctor. So panic or emotional arousal activation is very, very important to show you how much will be the degree of pain. We wanted to look at this data selectively among male patients. You know why? Because in the West, there are several studies on IBS in female. Peculiarly, in India, we get 50-50. That means our IBS patient, 50% are male. So what we did is we took selectively male patient to see that the emotional arousal activation that is reported elsewhere in the other studies, does it happen in male patient as well? So we took female patient, a male patient with IBS, no female patient. We took male patient with IBS, and we took healthy control, again, all male. Then what we did is we inflated a balloon in their rectum. Before inflation of the balloon, we did functional magnetic resonance imaging on the brain to look at the degree of activation of different areas such as somatosensory areas and emotional arousal areas. And what we found is it is something like female only. There is not much difference. Also, we all know that glucocorticoids are stress hormone. And what happens is CRH, corticotropin releasing hormone liberated from the hypothalamus, determines how much ACTH will be liberated from the pituitary, and that determines how much actually glucocorticoids will be liberated. There are several studies. One of my friend from the Japan, Shin Fukudo, did a lot of studies on this. They showed there is an excessive CRH and corticotropin system in IBS patient. And we all know pituitary, hypothalamus, and our autonomic nervous system are closely related. So therefore, it is very easy to understand how gut is related to the brain. Now, serotonin is very, very important. And in fact, I'll tell you, 40% of the body's serotonin is in the brain, and 90% is not in the brain. And the serotonin is liberated by the enterochromaffin cells of the crypts of Lieberkühn in the intestine or gut. Now, the serotonin is responsible for secretion in the gut, responsible for sensation of the gut, and responsible for increasing the motility of the gut. So if somebody has excess serotonin, the fellow will have IBS diarrhea or functional diarrhea. If somebody has less serotonin, he will have IBS constipation or functional constipation. And I all know, you all know that psychiatrists modulate serotonin with multiple drugs, because serotonin is also important in the brain for emotion, depression, pleasure, and everything. Now you do it more, but gastroenterologists had not been doing much with serotonin, but with time, gastroenterologists are also changing. Somebody was talking about microbiota. This is one of our study. मैं अभी class ले रहा हूँ थोड़ी देर. So this is one of our studies where we looked at immune activation in relation to gut microbiota of IBS patient and control, and we found immune activation in response to gut microbiota dysbiosis is very, very important. One more thing here is serotonin is one which is metabolized to melatonin. So melatonin is the sleeping hormone. Now, see, this is very, very important. You know why? Because people have studied long distance pilot, a pilot which flies plane, let us say from Delhi to, let us say, US. He's not sleeping the whole night. People have studied night shift nurses, their night shift duty and their day shift duty. And they studied their visceral sensation, they studied their compliance, they studied their gut sort of bowel movement and constipation, and they found sleep deprivation changes the visceral sensation, changes the gut motility, causes bowel disturbances. So IBS patients often have sleep disturbance. As high as 10 to 20% patients with IBS have sleep disturbance, and many gastroenterologists unfortunately do not look into this issue. And until unless you correct their sleep disturbance, actually they are not going to improve. Now, one of the questions that Dr. Adarsh Tripathi asked me, could IBS be misrecognized? Is it possible that when he goes to psychiatrist, he get a level of anxiety disorder? Yes. You see, when the fellow comes to a gastroenterology clinic, he get a diagnosis of IBS, constipation, diarrhea, but his psychological issues are missed, his sleep disturbance is missed. If he goes to a rheumatologist, he gets a level of fibromyalgia, chronic fatigue syndrome, physician diagnoses him as amoebiasis, gynecologist diagnoses him as pelvic inflammatory disease, and even surgeon does cholecystectomy, appendicectomy, thinking that this is cholecystitis and appendicitis. So therefore, it is very important that we do a wholesome practice, look at the patient as a whole and not in partiality. Now, one of the job that was sort of asked, one of the thing which Dr. Adarsh Tripathi asked me to do is what all drug we can use in the IBS patient. I tell you, drugs will depend on what type of IBS you are talking about. Are you talking about constipation predominant IBS, or are you talking about diarrhea predominant IBS? I told you constipation predominant IBS often have a slow motility, and the slow motility may be because of low serotonin. And we all know there are serotonergic agonists which work in gut level. What are the serotonergic agonists? Cisapride is a serotonergic agonist. Tegaserod is a serotonergic agonist. Both the drugs are withdrawn from market, but you have prucalopride now. So prucalopride is a safer serotonergic agonist. So if somebody has a constipation, particularly slow transit constipation, I will give him prucalopride. Obviously, constipation patient will benefit from osmotic agent and secretagogue. This will include osmotic laxative, lubiprostone, which is a chloride channel activator, linaclotide, which is a guanylate cyclase activator. So therefore, guanylate cyclase will lead to more water secretion in the gut and therefore improve constipation. There are newer drugs such as, I think because this is not there in our market, we'll not talk about it. When we talk about IBS diarrhea, I'll tell you, bile acid malabsorption can cause diarrhea. And not uncommonly, IBS patients, particularly those who have symptoms of diarrhea following cholecystectomy, have bile acid malabsorption. So those patients can be treated with cholestyramine, cholestyramine, and colesevelam. Gut microbiota dysbiosis is more common in patients of diarrhea IBS, and we treat them with rifaximin. Fecal microbiota transplant has been studied, but I tell you, FDA has warned that fecal microbiota transplant should not be used in the therapy of IBS now till we get more literature on this because of the side effect and mixed result. Obviously, IBS-D patient has fast motility, and the fast motility we treat by loperamide, difenoxylate, anticholinergic drug, including tricyclic antidepressant. Here we do not use tricyclic antidepressant for mainly its antidepressant activity, but mainly because it is anticholinergic as well. We also use opiate agonist, mu receptor agonist. These are acimadolin and eloxadolin. IBS-D patients often have high serotonin. So we give serotonergic blocker. These are ondansetron, ramosetron. In West, they also have limited availability of cilancetron, allocetron, but cilancetron, allocetron are not preferred because this cause ischemic colitis. Now, if pain is the predominant symptom, we try anticholinergic, we try smooth muscle relaxation, we try calcium channel blockers such as pinavarium, otilonium, and we also give psychotropic, not because they have the ability to change the mind, but also because they are visceral neuromodulator. They work in the little brain. Okay, if somebody has psychological issues, disturbed sleep, we handle it with that. I have a psychologist in my own team, and I think she must have joined this meeting. Now, these are the meta-analysis of tricyclic antidepressant and SSRI. Now, in the Rome Foundation, we have changed the name of these now. We say these are visceral neuromodulator. Why do you say these are visceral neuromodulator? Because people have found that these drugs even work when the fellow do not have any psychiatric issue. Second is this drug work when even you give a dose much lower than you use in your patient with psychiatric disorder. Third is people have shown that if you give this drug, actually the compliance of the viscera changes. I'll share with you a study very soon. So also it takes away some of the stigma, because unfortunately the patient do not want any drugs that modify their brain function. They're also worried about sedation. So we say this is a neuromodulator. This is the study where they looked at visceral sensation or rectal sensation among patients with IBS with placebo and pregabalin, and they looked at sensation increasing or rather what balloon volume patient could have tolerated without desire to defecate and pain, and they showed pregabalin change this. This is another randomized controlled trial recently. Melatonin has been studied in IBS, and it is also studied does it work in IBS? I tell you, the results are very mixed. I do not prefer this drug very often until unless bloating is a major symptom. So in patients who have a lot of bloating or fullness in the abdomen, we try probiotic drug. If probiotics don't work, then we try rifaximin, which alter the gut microbiota. This is one of the consensus that we published recently on probiotic and whether this led to symptoms, global improvement, bloating score improvement, and flatulence score improvement, and it showed positive result. Also, gas is produced by the food that we eat. It is not only produced by the microbiota that we have, because microbiota determine how much gas will be there in the tummy, but also food determines how much gas will be produced in the tummy. And there are food which are called FODMAP. FODMAP means fermentable oligo di monosaccharide and polyol. So if a food has a lot of FODMAP, fermentable oligo di monosaccharide and polyol, these are fermented in the gut, and this produces a lot of osmotically active substances causing diarrhea and flatulence. And these include fructose, lactose, fructans, galactans, and the polyols. And what we do is that if you go to this website, www.spreadhealth.in, it is written here. We have displayed this diet chart. So that we tell our patient that if bloating is his major symptom, we tell them, or flatulence is the major symptom, we tell them, try to avoid this high FODMAP food for 2 to 3 weeks and see what happens to you. If you improve a lot, I think then we re-challenge them with all these high FODMAP food one after another. When you do it one after another, what is the advantage? Advantage is you discover which particular food is the offending agent and avoid this particular food long term. But obviously, avoiding all these long-term, all these high FODMAP food is difficult, particularly in India, because a lot of our people are vegetarian, and we have all the high FODMAP foods in plenty in our diet, such as garlic and onion and so on. Now, constipation we treat with psyllium, that is a soluble fiber. We give polyurethane glycol. We give chloride channel activators such as lubiprostone, guanate cyclase agonists such as linaclotide, serotonin agonists such as chloride, abdominal pain, I do smooth bowel relaxation, peppermint oil. Is that if somebody has diarrhea predominant IBS, we prefer tricyclic because tricyclic have a lot of anticholinergic activity. Whereas if somebody has constipation predominant IBS, we prefer SSRI, thinking that SSRI will increase the amount of serotonin in the synaptic cleft in the enteric nervous system, though we need more evidence on that. And if the pain major symptom, along with constipation, we prefer adrenergic system, and therefore we all know nociception is carried by the adrenergic system. Coping strategies are very, very important. And that is where we really need your help. Stress management, group therapy, cognitive behavioral therapy, relaxation technique, all these are very, very important because IBS is a chronic disease and patient has to live with this disease. So they have to learn how to cope with this disease. With this, I thank you so much.
Uh, Dr. Sandeep Grover, sir.
Yeah, definitely.
We have a lot of questions, sir. You can.
But
We
I will.
have some
I will,
time.
sure.
Yes.
Uh, at the outset, I will first like to thank Professor Ghoshal for an excellent talk and making us all knowledgeable about the topic and giving us a gastroenterologist perspective on this topic. As psychiatrists, many times we see patients with depression, with comorbid IBS, or patient of anxiety with comorbid IBS, and at times, and we are at loss how to manage them. But after this talk, I think many of our doubts have been clarified, and but still we'll take a few questions which have been are in the chat box. So uh, Professor Ghoshal, I'll be taking a few questions. Sir, can you unmute yourself?
Actually, I will tell you something. I'm really sorry that I have another meeting lined up at 3 p.m. So we have to really disappoint you at 3 p.m.
Sure, sir. We will try to finish by 3 p.m., sir. We'll try to finish
Yes,
that.
thank you.
There is a question from Dr. Jabbar that is there a relationship between the use of antibiotics in children and development of behavioral and emotional symptoms during adolescent or adult life? I think we'll take up this later. The question is, will persons with IBS get over it over the years? So, Professor Ghoshal, what is your take on that?
Yeah, I tell you, practically speaking, they don't really get over it. The type of FGID changes. There are multiple studies now to show the type of FGID changes. Somebody who has functional constipation become IBS-C. Somebody who has IBS-C becomes functional constipation. So they don't recover, truly speaking. But what happens is there is a type of IBS called post-infection IBS. So post-infection IBS has good prognosis. In fact, there are at least 3 studies, 2 from South Korea and 1 from probably Europe, which showed that post-infection IBS in 5 to 10 years may disappear.
Thank you, sir. There is another question. Based on what we have already learned, is there any evidence of any SSRI which can worsen the predominant diarrhea type of IBS?
Yeah, it is a very good question, but unfortunately, all these neuromodulator have not been extensively studied. So therefore, your question, to the best of my knowledge, we don't have a great answer.
Okay, okay, sir. We'll come to that later. How the next question?
If
How
you
common?
use, yeah, yes,
How,
tell me.
how common is IBS in children and adolescents? And what is the common presentation in children and adolescents?
You see, the IBS in children and adolescents present almost similarly. But what happens is the diagnostic level that many of these pediatricians give is not IBS. They say recurrent abdominal pain or RAP. So the presentation, if you go to details of these patients, you'll realize they are presenting quite similar to the adult. But what happens is if you look at the diagnosis by the pediatrician, often the diagnosis will be RAP, so recurrent abdominal pain. Hello? And जी.
There are others. There are few more questions we will take up once sir leaves. I think some of us can answer those questions. I'm just selecting those questions which
Yes, sir.
we can just focus on Professor Ghoshal.
Yes, sir. Sure.
Yeah.
Sorry, there was a phone
Sir,
call. Yes.
the next question is, if somebody is using medication like calopride and pregabalin, what is the duration for which this should be used? How long these medications can be used, and how safe
Yeah,
are
you
they in
see,
the
in
long run?
procalopride, yeah, is very good question. Procalopride, there are studies up to 4 years. So what happens is, it has been found that there is not a major problem to use this drug up to 2 to 4 years. Only thing is that people have found that as you keep on using this drug, there is a loss of response. So you may have to add a second drug, may have to change the dose if it is possible. Like if you are already given the maximum dose, you can't change it. As far as pregabalin is concerned, you know better than me, we don't prefer pregabalin. That study that I have shown is fine. That is a study only. We don't like because their pain we manage by other method rather than pregabalin because of the concern, so many concern of side effect with pregabalin because it will be used long term.
Okay. And in the similar line, the next question is about duration of use of rifaximin and ondansetron. So how long to
Rifaximin
use?
is very clear. Yeah, rifaximin dose is 550 milligram 3 times daily only for 10 to 14 days, not beyond that. Now, what happens is if the fellow responded, the response often lasts for 8 to 12 weeks. Now, after 8 to 12 weeks, if the fellow recurs, you can retreat with rifaximin. Now, the target 3 studies published by Anthony Limbo about 2 3 years ago showed that you can use rifaximin up to 3 to 4 times.
Okay.
Beyond that, you don't have data. But I know some patients keep on using rifaximin. Actually, it should not be done because it really spoils your microbiota.
Okay. The next question is, there's a common preference of sulpiride among the gastroenterologists, which is a derivative of amisulpiride and antipsychotic. So would you like to share some insights about that? Why
No,
that is
I don't
preferred?
use sulpiride. I don't. Yeah, I don't use sulpiride. You see, unfortunately, we all know. I don't know whether I should be telling that. Many a time, drugs are used not only scientifically, but also how much boost somebody has given to popularize that drug. So it is unfortunate. I do not use sulpiride. It has side effect, including sedation, galactoria, and is not a very effective drug. We have much better drug than sulpiride, much safer drug. So if gastroenterologists are using it, I'll say, please avoided using sulpiride too much.
Okay. I think the rest of the questions we will discuss once we uh, thank Professor Ghoshal. So I'll request my co-chair, Dr. Suresh Badamat, to thank Professor Ghoshal so that then we can continue from there. Dr. Suresh?
Sir, Dr. Suresh is he
Yeah.
called me, he is engaged somewhere.
Okay. Dr. Adarsh, please take over then. Yeah, please. Yeah.
So, as Dr. Professor Ghoshal has to leave now, so we are very thankful for a very insightful and a very comprehensive presentation by an world-class leading researcher in the field. Sir, we have been very much we have been enhanced in our knowledge and our approach and understanding related to some of the functional gastroenterological symptoms which often occurs both in psychiatric disorders and gastrointestinological disorders. There have been a lot of changes regarding understanding of psychotropic medications in psychiatry also. And now SSRIs are not often called only antidepressant. They seem to influence the genetic functions and molecular functions at much deeper level. So the way gastroenterologists are changing the name, that it is visceral modulator, sensitivity modulator, in the same way the understanding is changing in neuropsychiatric disorders also. So with this, I thank you very much for your giving us your valuable time and your grateful presence. We are thankful to you, sir.
Thank you.
Thank you, Professor Ghoshal. We know that you are short of time and you have another meeting lined up. I take this opportunity to thank you, and I hope that next time we again meet and we'll have much longer opportunity to discuss issues with you. So thank you once again. Thank you, sir.
Thank you so much.
Yeah. So Adarsh,
Yes, sir.
Can
So please, sir, we can continue with the questions.
no,
And
we have.
yes,
We
sir.
will start with the open house discussion and the clinical queries.
Yes. There are a lot of question answer sections also, sir. Please take up them also. So we can. Yes.
So for the open house discussion and the clinical discussion, I invite my friends, Dr. Nishant Goyal from CIP Ranchi. Dr. Nishant.
Sir, I am here.
Yeah. Good afternoon. Dr. Siddharth Sarkar, another dear friend from AIMS
Good
New
afternoon,
Delhi.
sir. Good afternoon.
And Dr. Sujit K. Kar from KGMU Lucknow. Of course, Dr. Vikas Menon is with us, who introduced the topic. So, and Dr. Adarsh.
Yes.
And Dr. Adarsh, I'm not aware of who is this Birinder Singh.
Sir, sir, there are three open house discussant with us today. So I'll briefly introduce them one by one.
Yeah, sure.
Yes. So we have Dr. Nishant Goyal with us. He is Associate Professor of Psychiatry and in charge of Center for Child and Adolescent Psychiatry and FMRI Center of Cognitive Neuroscience in CIP Ranchi. That is a very prominent institute. He is currently Joint Secretary and Founder Member of Neuromodulation Society. He is President-elect of Indian Psychiatric Society, Jharkhand State Branch, Editor of Eastern Journal of Psychiatry, and his primary area of interest include child and adolescent psychiatry, non-invasive brain stimulation. With this, I welcome you, Dr. Nishant Goyal. We have
Thank
Dr.
you,
Siddharth
Adarsh.
Sarkar. Yeah. We have Dr. Siddharth Sarkar with us. He is Associate Professor of Psychiatry in Department of Psychiatry and NDDTC, AIMS, New Delhi. He has a large number of publications in national and international journals and presented both at national and international levels. He is winner of Sarda Menon Gold Medal in Psychiatry. We welcome you, Dr. Siddharth.
Thank you, Dr. Adarsh. Thank you for coming.
And we have our own dear friend, Dr. Sujit Kar with us. He is additional professor of psychiatry in King George Medical University, Lucknow, at Department of Psychiatry. His primary research and clinical areas of interest include brain stimulation and organic psychiatry. He has a large number of publications to his credit current and his predominant, as I already mentioned, his predominant interest area is brain stimulation and organic psychiatry and consultation license psychiatry. So I welcome all of the open house discussant for this webinar. Now, as we have large number of questions, so we sort of try to sort out the questions as per the predominant area of interest and expertise. Sandeep sir. Uh, so there is a large number of questions asking about use of antibiotics and its developmental impact on children and adolescents. And if there is early exposure to antibiotics can lead to some emotional and psychological issues and relation of gut-brain axis to brain development. So Dr. Nishan, uh, 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 can you respond to some of the queries in this regard?
Sure, Adarsh. This is a very important topic, and in today's context, when we use, like antibiotics, like pain removal, removing pills, and something like that. So we do have enough evidence to suggest that there is a bidirectional communication between the development of gut microbiota in the fetus. Now, whenever you use antibiotics, even antibiotics which are used, in pregnant women during their pregnancy, they actually act as a barrier to for optimizing the infant gut colonization. There are a lot of studies and there are a lot of associations which have been shown that prenatal antibiotic use and reduced abundance of healthy bacteria in the offspring at birth, which was found. Now, one of these studies, they say that it's there is up to 80% increased risk of the child developing obesity later on, whose mother has received antibiotic prenatally. So at time there is one point of time when and we, as we know, that many of the prescribed antibiotics, they do cross the placenta. So yes, not only antibiotic use, it affects the life of the or the bacterial colonization in vitro, but also it has got effect after the birth, where they have problems like obesity. They have problem like problems in colonization of the gut, in that matter of fact. So this is regarding antibiotics. Along with that, there is enough evidence to suggest that there is a significant impact of development of gut microbiota axis in children and adolescents after birth. The factors include stress, that includes both maternal stress in utero or otherwise. Even situations like using C-section or cesarean section for delivery. So mode of delivery has also been found to have direct impact on the microbial composition in the child. And there are many other factors like if I go into the details, there are, how the delivery is done. Like, one more important thing about the like cesarean section delivery is it delays the skin to skin contact between the mother and the child, and the time when the mother starts breastfeeding also gets delayed. So that also alters the bacteria, microbiota in the neonate or the infant. So these are the various things which cause some developmental changes in the gut axis part of the microbiota gut axis. And definitely it has as I said, there are bidirectional connections, like uh, the immune system, the endocrinal system, and other things, happening in the brain. The brain is also developing at that time very fast. So all those things, they affect the gut. And it has been demonstrated that serotonin is not only present in the brain, serotonin is also present in the gut also. So there's a lot of evidence to suggest that. So it also regulates the functioning of the brain, and that is how we see that children with impaired or children with deviant development of microbiota or the microbiota ecosystem, they are prone to have various emotional disorders, various cognitive disorders. I think uh, Dr. Sujit has already shared how autism is associated with problems in gut brain axis and other things. So these are a few points I wanted to make, particularly in this point of time. Over to you, Adarsh. Thank you.
Yeah. Thank you, Dr. Nishant.
Thank
I
you.
just uh, I would just like to add one point here what Dr. Nishant said. When we talk about the emotional and the behavioral symptoms associated with use of antibiotics, we need to understand that we are talking about psychiatric side effects of the antibiotics and others. So as this has been reported in adults, the similar side effects have been reported in children and also children and adolescents. These are usually in literature what we understand that they are not studied very systematically. That's why we do not have the exact incidence rates, and they are mostly referred as non-specific behavioral symptoms associated with use of antibiotics and others. But there is a huge research potential in this area. So with
Absolutely.
this, we will move to the next question. Uh, Based on what we have already learned, is there any evidence that synergic drugs worsen worsen diarrhea predominant IBS? So I would request Dr. Siddharth, if you are okay with taking up this question.
Well, thank you, sir. Yes, SSRI is worsening this, diarrhea, predominant IBS. It's a theoretical possibility, and it should occur and seems to occur. But I won't be able to tell the clinical experience or the extent of it occurring. But yes, of course, uh, as excess of serotonin is likely to worsen the diarrhea predominant IBS, I think it should.
Yeah,
So that would be it, sir.
yeah,
Well, can I contribute to
Yeah.
this?
sure.
Sir, as the presentation by Dr. Ghoshal mentioned and our clinical experience, like our clinical experience of using SSRI, and we know that a lot of patients, specifically patients of anxiety disorder, do manifest a lot of symptoms related to GI dysfunction, and they do present with symptoms of visceral hypersensitivity and the symptoms of that increased frequency of maturation and increased frequency of defecation whenever they are anxious. So in that kind of patient, what have been my personal experience that utilization of SSRI is not an issue with them, but the principle of using very low dose of SSRI, at least initially, is very important. That you use very low doses of SSRI and build it up as the patient start tolerating. In addition to that, what I have personally experienced, that if the person is having significant issues with GI tolerability of SSRI, in addition to using very low doses of SSRI, conjugation of some PPI or ondansetron for initial few weeks facilitate the tolerability of SSRI for that particular client. And in long run, it has been noticed that the patients, whether they are having predominant diarrhea type or predominant constipation type of GI symptoms, they will benefit by optimal use of serotonergic medications.
Yeah, thank you, Siddharth and others. Just to add up there, what we need to understand when we talk about SSRIs, they are not just acting on serotonergic system, and they also act on other systems, predominantly anticholinergic system. So, for example, if we try to understand SSRI, they are, although we talk them as a homogeneous group, but each SSRI has its own characteristics. For example, paroxetine, which has high anticholinergic property, can actually lead to constipation. So we need to understand the differential effect of various SSRIs on the GI tract. That's number one. And the number two, the diarrhea can worsen if in the initial phase, as you see the nausea, diarrhea, these are common side effects in the initial phase of using SSRI. So if you're, as others pointed out, that if you're using the lower doses, at the time of starting, and you're putting PPI cover that can help you in overcoming these side effects. But again, you have to be very clear about the indication why you are choosing SSRI. That's something which we need to keep in mind. I move to the next question. This is for Dr. Vikas. Uh, uh, what is the role of exercise and meditation in management of IBS? Please unmute yourself. Yeah.
Yes, sir. Thank you for the question. I think what we have learned from the discussion so far is that there is a biopsychosocial model that is important in the genesis of IBS symptoms. So, from the point of view of management, also, whatever factors we can tackle, we should focus. So, Uday sir has already spoken a lot about the pharmacological management, but I think lifestyle factors and psychological and social factors. We talked about the lack of physical activity, which can also contribute to the symptoms of IBS, and also diet modifications. All these things are also contributory and it's definitely a multidisciplinary, multimodal management only, which will help to optimize the clinical outcome. So from that perspective, exercise as well as meditation will help in stress reduction, because exercise releases the body's own the endorphins, enkephalins. Sir also mentioned that in his presentation about these are the body's own stress busters. So stress relief, anxiety relief, all these things will contribute to the management of IBS. We have to look up the specific evidence to see how much individually these therapies may contribute. But I think the sum of the intervention will be more than its parts when we talk about the management of IBS.
Thank you, because I think you have summed up well that anything which has a mechanism to reduce stress, let it be yoga, let it be relaxation exercises, let it be aerobic exercise, whatever you want to do, if anything which acts on a stress mechanism can lead to reduction in the symptoms of IBS. That's what we need to understand. This question I will request Dr. Suji to take up. Over the time, whether the symptoms change from diarrhea to constipation in patient with IBS.
Thank you, sir, for the question. It is well known that patients who with irritable bowel syndrome who have symptoms of constipation, they can develop diarrhea, or those who are having symptoms of diarrhea in the course of illness, they can develop symptoms of constipation. Even has been clearly mentioned in the literature that sometimes diarrhea and constipation, they may alternate. So it is quite evident.
Yeah, thank you. Thank you for that clarification. I will request the next question to be taken up by Dr. Adarsh.
Yes.
That what are the reasons for gender differences of IBS?
Sir, in my understanding, the reason for gender differences of IBS lies in the basic etiopathogenesis. Like we are now understanding that the basic etiopathogenesis of intestinal irritable bowel syndrome also relate to the dysfunction in stress response system of an individual. These stress response system are modulated by the genetic and molecular mechanism, which lies at the response that the person is unable to deal with the stress. Partly this is responsible for production of IBS symptoms, and also the symptoms which are related to visceral or somatic hypersensitivity. So this visceral and somatic hypersensitivity, in addition to dysfunctional stress response system, is partly responsible for pathogenesis of this disorder. What was the complete question, sir? I forget a part of question. So can you please?
What is the reason for gender differences of
yes.
IBS?
So,
okay.
so the gender differences, like we know in anxiety disorder and depressive disorder, that this gender differences is contributed by etiological manifestation, as well as the specific biological differences which are influenced by hormonal profile of gender, as well as the socio-cultural conditions of individual, the lifestyle the people are able to live, the kind of comfort and the kind of supportive things that they are able to avail in the life. There are significant differences among the gender, the way they are able to achieve, including the substance use, including the patterns of sleep and rest. So all these factors, I think, influence the gender differences. That is why possibly we can see that the gender differences are not homogeneous. In presentation, Dr. Ghoshal mentioned that the gender differences in India are different from gender differences of prevalence in Western countries. So this is not complete, cannot be completely explained on the basis of biological regions. There are lifestyle and socio-cultural factors which are responsible for this.
Thank you. I will just add one line here that basically we need to understand that IBS at one level, when we talk about the gut-brain axis or brain-gut axis, we are talking about the stress perception. And we know that females are exposed to much more stress than men because of the multitasking and the different kind of roles they play. So that may be the another thing which can explain these differences. There are a few questions that what are certain Indian food diets that can be advised to the patient with IBS? I think Dr. Ghoshal has covered, so I'm not taking up this question. The next question, I will leave it this open to all my friends. Anybody can take up and raise the hand. Is there any relationship of IBS with functional dyspepsia? So anybody wants to take up can unmute himself.
Sir, just a brief that what is my understanding that there are a large group of disorder which was used to be called as functional gastrointestinal disorders. This functional gastrointestinal disorders included functional dyspepsia, irritable bowel syndrome, functional diarrhea, functional constipation, functional repeated abdominal pain syndrome. This a whole lot of group of syndromes. And there is a close etiopathological correlation among all these disorders. Like we know that there is close etiopathological correlation between all of the anxiety disorders and depressive disorders, like we can common mental disorder group. So these are closely correlated, and subtle differences in etiopathological mechanism might predispose one person for functional dyspepsia and other person for functional gastrointestinal disorder. In functional dyspepsia, predominant involvement of upper GI tract is important, and we know that acid production is also influenced by the psychological conditioning of individuals. So I think probably that is the link of these two disorders.
Thank you, Dr. Adarsh. Yeah, Dr. Sujit, please go ahead.
Sir, just I want to add one more thing. When you see the gut and brain axis, there is an important link, that is the vagus nerve. So vagus nerve is predominantly a parasympathetic nerve, and it is innervating the upper GI as well as a part of the proximal part of the lower GI tract. So it increases the secretion of acid in the stomach. It increases the motility of the gut. So increased vagus activity is basically produces increased acid secretion as well as increases the gut motility. So it is increased acid secretion is responsible for the dyspepsia related symptoms, acid peptic disease because of GERD like symptoms, whereas increased gut motility is responsible for diarrhea. So this hypothesis explains both the functional dyspepsia as well as diarrhea related symptoms due to irritable bowel syndrome. So it is having a bidirectional relationship. Similarly, the vagus activity is also modulating the mood symptoms and behavioral symptoms. It is linked with some important areas of the brain that is responsible for regulation of the mood. So it is an important connecting link that explains functional dyspepsia as well as irritable bowel syndrome in a continuum.
Okay.
Dr. Sujit, sir, just we have received certain questions in email also. And the one question which we received in this context was that if there is any utility of any brain stimulation or somatic strategies for functional gastrointestinal disorder. Can you tell about, is there any evidence of vagus nerve stimulation or other brain stimulation techniques for any functional gastrointestinal disorders?
Okay, sir. So far as functional gastrointestinal disorders is concerned, there is alteration in the, whenever there is a functional gastrointestinal disorder, there is alteration in the gut microbiota and change in the pH, change in the uh, physiological milieu within the gut. So that change in the physiology causes release of certain chemical mediator cytokines that can stimulate the free nerve endings of the vagus nerve, and that transmission can modulate the activity of important brain areas, particularly the brainstem areas like locus coeruleus, which is responsible for regulation of the mood. So there is a connecting link. It has been seen that individuals who are having celiac disease, they have a change of gut milieu that causes release of cytokines, and cytokines in turn stimulate the vagus, and vagus in turn causes change in the cognitive and cerebral cortical excitability of the brain. So it causes more of a hyper excitable brain. So individuals with celiac disease, they usually have some cognitive symptoms like difficulty in concentration, difficulty in memorizing things. So that is classically called as brain fog. So it has been a direct link between gut disease with the cognitive symptoms, with the mood symptoms of the brain. So though it is not much studied, like vagus stimulation can cause change in the gut milieu. There are some evidences, there are some recent publications published in 2018 and 19 in Frontiers of Psychiatry and some other high impact journals that say that there is a possible role of vagus nerve stimulation in regulating the mood, that is classically FDA approved for that, but it can also control the functional GI symptoms. So it has been proposed, but there is not much evidence. It is not approved so far as US FDA is concerned. Then regarding other neuromodulation techniques, like if gut change in the gut microbiota causes alteration in the excitability of the cerebral cortex, then of course the cerebral excitability, like they did an experiment, they restricted the gluten-free diet, they restricted the gluten-rich diet. So when the gluten diet is restricted, then the cortical excitability is reduced significantly. When the individual takes gluten-containing diet, the excitability further increases. So there is a possibility of dietary modulation. By altering the dietary factors, you can modulate the cortical excitability also. So what I will say, there is a bidirectional relationship. The approach can be bottom-up approach, it can be top-down approach. Bottom-up approach is just like you are giving some probiotics, you are changing the microbiota of gut. So by that you are changing the psychiatric symptoms, mood symptom, behavioral symptoms. So this is a bottom-up approach. Another approach can be top-down approach, like you are targeting the cortex, you are targeting the cortical excitability or modulating the cortical activity, thereby you are modulating the activity of the gut. So we are now, so far as the research evidence is concerned, we are more familiar about the bottom-up approach. A lot of evidences exist regarding add-on probiotics, add-on so many things in autistic disorders and other conditions, like you add on a probiotics. But very limited evidences, like you do some activity that modulates the cortical activity and that will reduce the gut activity. We do some things like Dr. Vikas just pointed out, yoga meditation. Somebody is doing yoga or meditation. That reduces the stress level. That normalizes the autonomic functions. So again, the gut activity is reduced. So this is a top-down approach. By doing the yoga meditation practices, you are regulating the cortical activity, thereby reducing the gut activity. But there is little research regarding the typical non-invasive brain stimulations like transcranial direct current stimulation or repetitive transcranial magnetic stimulation. There are very little evidences regarding use of these neuromodulation techniques in modulating the gut activity.
Thank you, Dr. Sajid. Sir, there are several questions related to substance use and its influence on gut-brain axis. We have received questions like if cannabis, how does cannabis influences gut-brain axis, and how smoking and tobacco chewing, which is very prevalent in Indian context, likely to influence these symptoms. So can we request Dr. Siddharth Sarkar to please
Yeah, so substance use generally have quite a detrimental effect on the course of irritable bowel syndrome and has quite an impact on the gut functioning. So as we know that cannabis it stimulates appetite and then it in high doses may uh, reduce the transit time, increase the transit time. But more than that, what is seen in commonly is that among substances, tobacco is a common denominator or a usual suspect that has been seen to have uh, many symptoms due to either direct effect or exacerbation of the pre-existing symptoms. So what happens is that tobacco consumption, either smoked or smokeless form, both leads to dyspepsia, right? So functional GI disorders, dyspepsia is a common symptom, so which gets exacerbated due to use of tobacco products, either smoked as well as smokeless. So there is flaring up of condition of IBS when the substance use increases, especially tobacco. Now, something interesting has been seen with alcohol as well. Now, what has been seen is that alcohol consumption, especially in excess amount, has been seen that in patients who are suffering from IBS, it increases their symptoms. So, someone who has been abstinent for some period of time and the symptoms are under control, if he or she takes alcohol in excess amounts, it may lead to flaring up of the IBS condition again. This may not happen in taking lower quantities. So this has been demonstrated that there is a difference between taking binge pattern drinking or drinking in heavier amounts vis-a-vis drinking in lower amounts. So there's some literature towards pointing towards that. So, substances affect gut in various ways. In fact, one of the important treatment methodologies of for IBS, which includes loperamide. So that is a kind of an opioid, and which is effectively used for treatment of IBS. And in certain instances, it has been found that some people misuse loperamide and they start taking in excess amounts, but that is pretty rare. But nonetheless, loperamide itself is a very good treatment modality when diarrhea predominant IBS is a concern for the patient.
Yeah. Thank you, Siddharth. Adarsh, do you have other questions on the email?
Sir, there are a lot of questions, but I don't think that we have too much time now. So it is your call that whether you wish to take a last question and.
Yeah. I'm leaving this last question for my friends. Anybody wants to take up this question? What is the role of low dose chlordiazepoxide plus trifluperazine combination in IBS diarrhea type? Anybody wants to take up this question?
Sir,
Yeah.
Sir, I can just speak from some evidence, some clinical experience that one of a very senior psychiatrist in Lucknow is very fond of prescribing this combination of low dose trifluperazine. That means 1 milligram of trifluperazine along with some, I think, 1 milligram of traxipheridol. That sort of combination is there. And I have seen it being used for a lot number of patients who have predominant GI symptom. And unfortunately, that senior psychiatrist is reducing his practice now. He is seeing very less number of patients. So a lot of patients are now seeking consultation from other doctors. And what I have noticed that I have not used primarily myself writing first prescription for this drug for any new patient, but I found that discontinuing this medication from the patient who are already on this combination is a very troublesome issue. That they are completely stable on very low doses of medication, but as soon you suggest that you can try discontinuing this medication, they will come back and say that their symptoms have started. So this is my little clinical experience that either they have developed a sort of dependence after using it for quite long time. Most of the patients are using it for several years, which I have seen. Or they report that they had these symptoms earlier, they have been given this medication, the symptoms subsided, and they are maintaining well. So this medication might be actually benefiting them for those symptoms, and it is helping without causing any side effect. I don't think that I've seen any patient explaining any significant side effect with this combination.
Okay. Nishant, you wanted to add something? Yeah, please.
Yes, sir. Sir, regarding use of chlordiazepoxide and other drugs, I think a fixed drug combination with clidinium bromide, which is an anticholinergic, and chlordiazepoxide is available in the market, and it is a very commonly prescribed drug by the primary care or secondary care physicians for symptoms of IBS. And
Right.
frankly speaking, I have also used this fixed drug combination. It comes by the name of Normaxin, 5 and 10 milligram, depending upon the amount of clidinium, with I think 10 milligram or 25 milligram of chlordiazepoxide. So I think it does help. But again, as Adarsh says, there is a chance of people getting hooked to it if we use it for a longer period of time. So we have to keep the patients on follow up, so that we can withdraw this medication when it is not required. Thank you, sir.
Thank you. I will just take maybe take the this so-called veto this power. That there is one question which somebody asked, that what therapy works should be started first, medical or psychological, as a first line therapy. So what I would just end up in concluding remarks of the webinar is that whenever you are planning to treat a person with IBS, it's not just you are treating IBS, you also need to evaluate the comorbidities. And if you have psychiatric comorbidity which warrant use of pharmacological agents, you do use it. But the best kind of a therapy for any patient is a combination of psychosocial interventions and pharmacotherapy. So with this, I will now hand over to Dr. Adarsh for final concluding remarks. And I thank all my panelist friends for being present here. And I hope that this webinar series will continue for a long run. We'll be able to have much more interactions with each other. Thank you, Dr. Adarsh. Please take over.
Thank you very much, Dr. Sandeep Grover, sir. I would invite any final comments from Dr. Vikas Menon, sir. Would you like to say something in the end?
No, I think this has been a very enlightening, interactive webinar, which has added to all of our insights about the etiopathogenesis and management of irritable bowel syndrome. And I think such interdisciplinary webinars must be needed to enhance, as a capacity building measure also, and to augment our approach and to increase the cooperation between the departments. I think it has been a wonderful experience, Dr. Adarsh.
Thank you very much. So in the end, I would like to thank all of our colleagues, our speakers and chairpersons who have taken their time out of their busy schedule to be in this webinar. This has been a really excellent experience of interacting and learning a lot of new things. To put this on record, we have 176 number of participants in this webinar, the highest number. I am thankful to every one of the participants who have been with us for this and had a very interactive and very interesting discussion. Keep on going. And in the end, I would also like to thank very much the entire team of Intas Pharmaceutical for supporting this endeavor and letting this happen. I would like to now ask that this webinar can be closed. Thank you very much.
Thank you, everyone. Thank you.
Thank you,
Bye-bye.
Dr. Adarsh. Thank you, everyone.
Thank you.
Bye-bye.
Thank you.
Bye-bye.
Bye-bye.
Thank you, everyone. Thank you.